So we are going to start with the psychiatry. It is super high yield, okay? And there are some points that we will go over again and again. We will read through and we will try to see what is important, okay? So first we start with psychiatric assessment. That is the most important step. So the patient comes in, you confirm for the name, age, and everything, and then you start. You also mention that there is limits of confidentiality. That means if your safety or the other person's safety is at risk, then you won't maintain it, okay? Obviously identify the patient, ask the name, age, gender, preferred nouns, okay? Living situation, any other marital status, house environment, children, source of income, occupation, drug therapy, and everything, okay? Next is main point is always the chief complaint, okay? This is the patient's own words. Basically the patient comes to you and what is the presenting illness, okay? So you start with the context, okay? Events, problems, any stressors, loss of job, or somebody's death in the family, such situations. And then symptoms, onset, duration, okay? So onset, when did it start? Was it sudden? Was it gradual? Did something happen that caused this to happen? Duration, has this been happening continuously, or is it progressing really fast, or does this happen in some bouts of times? Is it fluctuating, or is it related to day or any season? Okay, most important factor here is also to check for impact on functioning. This is important. You have to ask the patient, is this causing any problems in your social life, in your occupational life, your activity of daily livings or such, okay? And your coping strategies, any treatments that you're taking, any professional supports, okay? And then you also check for last period of wellness. The patient typically says, oh doctor, I was okay 6 months back, but now like since 6 months I'm having this problem. All right, so it's best to recognize when was the time like this all started, the symptoms started, okay? Then psychiatric function, okay? This is very, very important. So you always assess for mood, okay? Depression, mania, any other traumas, obsessions, compulsions, eating disorder. Then you check for anxiety. Basically, does the patient appear anxious, or they have too many worries or phobias or social anxiety? Psychosis, does the patient have a hallucination? Is the patient thinking like hearing auditory hallucinations, visual hallucinations? Check for any delusions as well. Safety and risk, the most important question. Any patient in psychiatry that you see, you have to assess them for suicidal ideation, any any intent or any plan, okay? Self-harm, neglect, or any even homicide. You have to ask them, do you think you might hurt someone? So it's important to know that, okay? Past history equally important, okay? You must check if the past, patient, when the patient walks in, you ask, okay, has this happened before in the past? Any other conditions that you had? Check for hospitalizations if you were admitted in the past, any emergency department visits, any past suicide attempts, okay? Self-harming behavior, superficial cuts or such. And check for aggression, violence, and legal charges as well, okay? This will tell you basically if the person has been under any substance abuse and was arrested for something, okay? And obviously ask the patient for treatment, PAM, hug, FOS, okay? So past treatments as well. So you check for any drugs, any any non-pharmacological treatments or anything like that. Substance use history, you always have to ask this here. It's very common. You can ask the patient, do you smoke, do you drink alcohol, do you use any recreational drugs? So all of that is covered under that question. And if the answer is yes, you ask like, okay, when did you first start, and typically how much do you take, or when was the last time you took, and periods of abstinence and any withdrawal symptoms, because seizures and delirium tremens are very common in alcohol withdrawal, okay? Check for any previous treatment, counseling, detox groups, impact on symptoms, motivation, past medical history, again important. Check for thyroid, okay? Hyper or hypothyroidism is super commonly related to psychological disorders in psychiatry. Always check for that. Any illnesses, any allergies, okay? medications if they're taking anything. Also check for herbal supplements such as John's wort, family history, psychiatric history, because the chances of having psychiatric disorders are higher if there is any first degree relationship. Okay, so you check the past history too. All right, and this is the main part, mental status examination. Okay, so the mental status examination is identified by this mnemonic, aseptic. So the first thing you do is when the patient enters, you check for appearance. Okay, is the patient clean, hygienic? Is the patient cooperative, collaborative, polite, friendly, evasive, agitated, aggressive, hostile behavior? This really matters. Okay, and then you also check for gaits and tics and any tardive dyskinesia, dystonia, catatonia. Next part is I think it was attitude was written somewhere here. Yeah, so you also check for the attitude if the patient is like cooperative or what. And then next part is the speech. Is the rate pressured or fast? Because in mania the patient's gonna have flight of ideas, so they're just gonna blabble about a lot of things. Okay, and it is slowed in depression, MDD, or cyclothymia or dysthymia basically, sorry. And you check E for emotions. Okay, mood. So mood is subjective emotional state. The patient will say that, doctor, today my mood is low. So that is the patient's mood, and the patient will tell you. Affect is basically objective emotional state. This is something that as a physician you will see, like, oh, if the patient is saying that the patient is sad, but he seems pretty happy. He's talking normally. Oh, doctor, I went out today. I ate this. I did that. So that is objective. Where the patient is saying, I'm sad, but you as a physician, you see and you're like, oh, the patient looks pretty okay to me. Okay. And in emotions, basically you have to check. First one was mood, and then the affect. How is the quality? Is the patient euthymic, depressed, elevated, anxious, or irritable? Range, is the range full, restricted, flat, or blunted? You will see flat effect in schizophrenia or negative effect in schizophrenia. Stability, is the patient like stable? Are they able to have comprehension of everything that's going on? Mood congruence, so basically inferred by comparing the patient's subjective mood with their effect. Okay, many clinicians use 0 to 10 scale, 0 worst, 10 best, when rating mood to a subjective norm for each patient. Alright, so A for appearance and behavior, A for attitude, speech, slow, fast, pressured, emotions. The mood is subjective. Again, the patient tells you, I am sad. Affect is when as a physician you objectify the patient's emotions, and you're like, okay, yeah, you're sad, you're happy, you do the main thing there. Okay, then perceptions. Perception is hallucinations. Sensory perception. What is the definition of hallucination? Basically, sensory perception in the absence of appropriate stimuli that is similar in quality to a true perception. So the patient will say, oh doctor, I'm hearing voices, but in reality there are no voices present there. That is patient's perception, that I can hear something, but there's no reality to it. Illusion, auditory is the most common one, and illusion is misperception of an external stimulus. For instance, if there is a rope on the floor, they will be like, oh doctor, there is a snake, but there's actually a rope present. Okay, depersonalization is change in self-awareness such that the person feels unreal, distant, and detached from their body. This is like an out-of-body experience where they're like, no, I am not this body, I'm not this human, I'm detached from the body, I don't feel my body anymore. And derealization is that they feel that the outer world is not real. They say, doctor, no, this world is not real. Okay. Okay. Moving on. So perception. Now we're going to check about thought, content, and processes. Okay. So for the thought, content, and the process. Okay, so first we're going to do the thought process coherence. Okay, whether the patient has coherence or is he incoherent. Stream, is it goal directed, is it clearly answering your question? Normal people will answer your questions. You ask them, okay, how many children do you have? They'll be like, yes doctor, I have 2 children. Circumstantial is basically speech that is indirect, delayed, and it's delayed in reaching its goal, eventually comes back to the point. So circumstantial is if you ask the patient, where do you live? So he will say, oh doctor, I was here, I was there, then my cat came, my dog came, and then this happened and that happened, I bought a new car. But at the end they'll be like, oh doctor, yeah, I live here at this address XYZ. Okay, so they come back to the point. Tangential is when the speech is oblique and it's totally irrelevant, okay, and it does not come back. They go on a tangent. If you ask them, where do you live, they will tell you everything possible on this planet except for the address where they live. Okay. Third is loosening of association and derailment. This is illogical shifting between topics. So shoe, rat, mat, cat, pat, and they will just talk illogical stuff. There is no like connection between anything. Flight of ideas, very significant, very important for schizophrenia patients, okay, to identify. This is quickly skipping from one idea to another where the ideas are like marginally connected, usually associated with racing thoughts. Okay, so they go, oh doctor, I know how to build a spaceship, I know how to go to Mars, and I know how to reach this, I have all the plan, I am the mastermind. Word salad is basically jumble words. They make no sense. They'll be like just, oh, cat is flying and the pigs are running and stuff like that. That makes no sense basically. Then perseveration is repetition of the same verbal response. If you ask the patient, how are you? They'll keep repeating, how are you? So that's perseveration. Echolalia is repetition of phrase or words spoken by somebody else. Okay, so they keep repeating the words again. And echolalia is when you ask them, how are you? They'll keep repeating, how are you? How are you? And perseveration is the repetition of same. They will keep saying day, 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 like same word, like it makes no sense. Thought blocking, sudden cessation of follow of the thought or speech. They will suddenly be talking about something and then they will suddenly stop because they don't remember what they're talking about. Clang association is speech based on sound that's rhyming and punning. So they will be like, flight, might, tight, bite, like all that rhymes. They will talk in that. Neologism is use of novel words or existing words in a novel fashion. Basically, neologism is they will create the new words that don't appear in any dictionary and they don't practically make any sense. Okay. Again, these boxes are super important. So cognitive assessment, use MMSE to assess orientation. So you want to always check the patient. Are you oriented to time, place? Do you know where you are? Memory, immediate, delayed. You ask them their name and you ask them to remember 5 objects and they have to recall in 5 minutes or 10 minutes. And then you check for their attention and concentration. You check for language, if they can read, write, spatial ability, if they can draw a clock or name the words backwards and forward, such things. And the total score should be, the total score is 30. If anything less than 26, it's abnormal. Anything between 20 to 25 is a mild. 10 to 19 is moderate, and anything less than 10 is super severe. So thought process is done. This was the process, the form of the thoughts. This is the content now. So check for suicidal ideation again. If the patient is like, oh doctor, I want to end my life, and doctor, I have a plan, I will go on the bridge and then I will drive my car and then I will jump and everything. So that is plan. Okay, and intent is, oh doctor, I'm going to do it on this Saturday. Okay, so that means they have a thought, they made a plan, and this is how they intend to like finish it, execute it. Active versus passive. Active is basically you make the plan and you're like, yes doctor, I want to go and hurt myself. Passive is when people say, oh, I wish I don't wake up tomorrow morning. That's passive. Okay. And always when you're checking for suicidal ideation, check for protective factors. What are protective factors? Protective factors are something that the patient says, oh, I look forward to this, I have a family, I have children, I have a wife who's waiting at home for me. Okay, such thoughts. Preoccupations, thought content. They're preoccupied by some thought or ruminations. Basically, they're reflecting on something that happened long ago and they keep circling back to it. Reflections and thoughts at length, not fixed or false. Obsessions, okay, recurrent, persistent thought, impulse, or image which is intrusive or inappropriate and unwanted. cannot be stopped by logic or reasons, causes marked anxiety and distress. Common theme: contamination, orderliness, sexual, pathological, doubt, or worry or guilt. OCD is very common. Then comes the magical thinking, superstitious belief, something is happening, something will make happen, normal in children. And they believe that, oh, I need to go run, touch this table, otherwise something bad will happen. Ideas of reference, similar to delusion reference, but less fixed, okay? Overvalued ideas, unusual, odd beliefs. They're not delusional, but they're just odd beliefs. Now, first rank symptoms of schizophrenia: thought insertion. They say, doctor, somebody has put these thoughts in my mind. Oh, doctor, somebody has taken out these thoughts from my mind. And sometimes they say broadcasting. So, broadcasting is basically, doctor, my thoughts are being broadcasted on TV or radio channels. And they're all delusional ideas, okay? Now, what is a delusion? Okay, delusion is a false fixed belief that is out of keeping with the person's cultural religious background and is firmly held despite incontrovertible proof to the contrary. Okay, basically they just believe that something is happening, somebody is talking about me, somebody is thinking about me, somebody is in love with me, somebody is planning something against me. So they have these thoughts, but they are not realistic. So here are those delusions. Number one is delusion, okay, the persecutory. Persecutory is a belief that others are trying to cause harm to me. The patient says, oh, doctor, I go to work and there's this colleague and he really hates me and he wants to cause harm to me. So that is persecutory. Reference is interpreting ordinary regular events or celebrities as having direct reference to you. References: the patient comes and says, doctor, I was sitting in the cafeteria and I felt like the whole office was talking about me. Okay, they make everything about themselves. Erotomania is basically belief that another person is in love with them. They will have this, belief that, oh, like Brad Pitt is in love with me or something like that. Grandiose is belief that you have special powers and talents and abilities, like you're the chosen one and you have some powers. Religious is belief of receiving instructions, powers from higher being, of a higher, you have some supernatural, super religious power. Some people have this. Somatic, belief that you have a physical disorder or defect. The patient will say, doctor, my body is not functioning well, my internal organs are rotting, I'm not this body. Nihilistic belief is that things do not exist and there is a sense that everything is not real. Nihilistic is like, nothing is real, my body is not real, I'm dead, everybody's dead, nobody's living. Okay, delusions, very important, definitely an MCQ on this. Okay, moving on to insight, the ability to realize that they have a mental health concern and to appreciate its implication as related to functioning, benefits, and treatment. Insight basically means the patient knows that there's something wrong with me and doctor, I need help. Such as in OCD, the patient be like, doctor, I'm tired of washing my hands, doctor, I'm tired of checking the locks all day. So that patient has an insight, versus somebody who has mania, they're like, no, I'm fine, my ideas are brilliant. Okay, next is judgment, recent behavior as they relate to safety, social functioning, treatment decisions. Okay, cognition, level of consciousness, you have to check if the patient is alert or if it's reduced or uptuned. Is patient that has no sense of what is happening around. Okay, orientation, so time, place, and person. You ask the patient, do you know what time it is? Do you know what place you are in? Are you in the, like, you are in the hospital? Person, who are you? Who are these other people standing? And then memory, immediate, recent, and remote. You ask them about the immediate, the name, the past, and you ask them to recollect the names of certain objects and check. Global evaluation for intellectual. Okay, you ask intellectual educational questions. Intellectual functions such as attention, concentration, calculation, abstraction. Okay, mini mental state examination and MOCA. Okay, they're very useful in screening. Okay, next part is assessment and plan. Historical and multi-axial model, diagnostic, and statistical manual of mental model is no longer used for psychiatry. Instead, A relevant psychiatric and medical diagnosis is simply listed. This is basically DSM-5. Okay, so obviously you identify the problem, the mood, you take the history like we mentioned, and then your approach with the management. Everything will have a different management. In some cases it's just going to be psychological, you'll offer CBD. Some you'll offer pharmacotherapy, ECT. Number one, the most important topic is suicide. Okay, important. Okay, very very important. Suicidal ideation and assessment. Asking patients about suicide will not give them an idea or incentive to die by suicide. The best predictor of completed suicide is a history of attempted suicide. So don't ever skip this history in psychiatry. No matter how happy or sad your patient is, you have to ask this question. On your NAC or skis, on anything in real life, every time make sure you ask such questions, okay? So importance must be screened for every encounter, part of risk assessment along with violation and homicidal ideation. So not just self-harm but even harm to others or any other plans to kill somebody, okay? Approach. Ask every patient, have you had any thoughts of wanting to harm yourself or kill yourself? Or passive ideation, like a death wish, where the patient would rather not be alive but has currently no active plan. Basically they say, I would rather not wake up, I would not mind if a car hit me. These are passive suicidation. That means they just casually they think that way. Active ideation is when they say, yes, I think about killing myself. You have to dig more. You cannot just say, okay, fine. Once they say, then you ask them for a plan. Do you have a plan? Intent. Do you think you would carry out this plan? And if not, what is stopping you? Okay. Past attempts. Number, lethality, outcome, medical intervention, intoxication, state, precipitants. Okay. If intoxicated. Assess suicidal ideation. Okay, we need to check suicidal ideation, onset and frequency of thoughts. When did this start? Okay, how often do you have these thoughts? Control over suicidation thoughts. Did you seek help? Can you call somebody for help? Then it's intention. So basically for suicide risk we do this. That person's mnemonic. Usually it's the sex is male. Men are known to commit more suicide, like completed suicide. Women attempt more, but men succeed more. Okay, age is above 60 years. There's always a history of, mostly there's a history of depression. Previous attempt is a big red flag. Ethanol abuse, people who drink. Rational thinking loss such as delusions or hallucinations, very common, because sometimes when they're hearing voices, the voices say go finish yourself, so they do it. History of suicide in the family. Organized plan, when you ask and they say yes, I have a plan, so those people are more risk. No spouse or any serious illness. Okay, then come here and assess again. Onset, frequency, intention, intended lethality. What do you think would happen if you actually took the pills? Okay, assess to means how will you get a gun? Time and place. Have you picked a time, date, and a place? Provocative factors. What makes you feel alone? Sometimes it's being lonely. Okay. Protective factors. We spoke about this. Do you have friends? Do you have families, pets, faith? Or sometimes your religion saves you, right? Sometimes a therapist, sometimes having spouse, sometimes having children. Then you assess for final arrangements. Have you made any arrangements? Have you written a suicide note? Have you made a will? Have you given away your belongings? This is very important, final arrangements. If a patient is saying, I have made the final arrangements, you have to admit the patient. You cannot let this patient walk away and go home. Practice suicide or aborted attempts. How far was the furthest you've gone in this? Put a gun to your head or held the medication in your hand. Stood at the bridge. It's important to ask, and these are very sensitive questions. Be very, very gentle when asking such questions, okay? Next is ambivalence. I wonder if there was a part of you that you want. This is you trying to create hope in their heart and saying, checking if there is still any hope present, okay? Determine the level of risk and then you develop a safety plan, okay? Safety plan will include a lot of things, such as, okay, if you're isolated, call this number, go visit somebody, don't stay alone, things as such. Okay, Assessment of suicide attempt. So you have to check the setting, okay? Planned versus impulsive. Substance use, intoxication, very common with alcohol intoxication. Medical attention, okay? Were you brought to the ED? Suicide attempt. Expectation of lethality, dying, reaction to survival, guilt, remorse, disappointed. Some people have guilt that, oh no, why did I try to do this? I shouldn't have done this, okay? So attempted versus completed, okay? That is 20 to 1. That is 100. Every 100%, one person dies, okay? 4 is to 1 an older person. This is a younger person. Male to female ratio for attempts is 1 is to 4, but the ratio of completed is more in men, 3 is to 1, okay? Risk factors for assessment is increases after age 14, second most common of death in 15 to 24, highest rates of completion in person in more than 75 years. Sex male, ethnic background white people, indigenous people in Canada, always assess history. Marital status, when there is a stressed out relationship sort of situation, always check and assess other stressful events and check if they have access to firearms inside their house. Psychiatric history will include all these disorders: eating, bipolar, major, mixed drug, panic, schizophrenia. All these disorders, somewhere or the other way, are related to suicide. Check for any stressful events, recent divorce, any person who has suffered a financial trauma or something, got laid off, situations like this. Psychiatric disorders such as mood disorders has 15% lifetime risk. Anxiety has more. Panic disorder, schizophrenia also has equal. Substance has, eating disorders, and all these disorders. Clinical features will include hopelessness, anhedonia. Anhedonia is basically lack of interest in any activity that they did previously and now they just don't want to do it. Insomnia, severity, anxiety, impaired concentration, psychomotor agitation, dissociation. Management, proper documentation, very important. For high-risk patient with a plan, intend to have access to legal vehicle and symptoms of psychiatric disorder, hospitalization. You have to hospitalize, okay? And then assess their decision-making capacity. If the patient demands to leave the hospital, do not leave the patient alone. Remove potentially dangerous objects from the room. If the patient refuses to be hospitalized, complete form of involuntary admission. Form 1 must be given in Form 30 to notify them that their admission. So basically you have to sometimes admit them against their will. For lower risk patient not actively suicidal, you discuss a plan. Okay, discuss protective factors, support their life, remind them of what they live for. They want to travel the world or they want to do something with their family members or something like that. Start managing the underlying problems. Now if the suicidal ideation is because of any of these mood disorders that we talked, if the patient is suffering from these disorders, obviously start the treatment and keep an eye and make a plan for the patient. Okay, make a safety plan that could include an agreement that you may need to make an agreement that not harm themselves. They will avoid alcohol, drugs, and any triggers. Contact a healthcare worker or a crisis call line. There's always an emergency call line, emergency department. They can just visit the department if they're feeling such. Okay, patients with depression, consider hospitalization. Okay, present, otherwise outpatient treatment is good. Okay, any patient with alcohol, this ideation increases, so you ask the patient to maintain abstinence from alcohol and other substances. Patients with personality disorders. Okay, so crisis intervention may or may not hospitalize. Patient with schizophrenia, psychosis, hospitalization might be necessary because there is an acute safety concern. Okay, patients with parasuicidal behavior, self-mutilation, psychotherapy with brief crisis intervention is necessary. Medications to treat the underlying psychiatric condition. Okay, so now we're going to move on to psychotic disorders. Psychotic disorders are very, very important. Okay, so the definition is characterized by a significant impairment in reality testing. These guys don't have reality check, basically. There are positive symptoms, delusion or hallucinations. Positive is basically why we're saying positive, not because they are any good, it's just that they are the new adapted symptoms that a person has. So addition of new symptoms is called positive. Not that they are nice, okay? Delusions or hallucinations, with or without insight to their pathological nature, grossly disorganized, abnormal motor behavior, including catatonia. Formal thought disorder, negative symptoms of, so now we said positive, negative symptoms of schizophrenia, diminished emotional response, affect flattening, they become quiet. Anhedonia, they don't like to do things they did before. Aviolation, alogia, they stop speaking, they become antisocial, they become isolated. Okay. So, what are delusions? Delusions are fixed, false beliefs that are not amenable to change in the light of conflicting evidence. The patient, even if you tell them, hey, nobody's talking bad about you, they'll still be like, no, 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 they're talking about me. That is delusion. Hallucination is perceptual experiences occurring without an external stimuli. Here they think that somebody is calling them, telling them, doing something to them, but there is nobody doing anything in reality. Timelines really matter, okay? Duration of the time differentiates the following three psychotic disorders. I cannot stress enough, all the three disorders are very, very important. Many MCQs on this, okay? So brief psychotic disorder, as the name suggests, it's brief, so it's less than 1 month. Schizophreniform disorder, so that's anywhere between 1 to 6 months. Anything that is more than 6 months is schizophrenia. All right. Okay. Differential diagnosis for psychosis. Okay. Differential diagnosis of psychosis. Differentiate among psychotic disorders and distinguish them from the other primary disorders. Consider symptoms, persistence, and time. Based on this, we make a decision what disorder it is. Symptoms. A primary diagnosis needs full criteria to be met. The mood, number one. The patient will have depressive episodes with psychotic features, mania episodes with psychotic features. Psychotic is basically consider symptoms in the criterion. It's right here. Okay. Brief psychotic disorder is more than one positive symptoms of the criterion A. Okay. So this is the criteria for schizophrenia. We will click here and see very soon. The duration is less than 1 month. Okay. Eventual return to pre-morbid condition. Brief psychotic disorder. Schizophreniform is 1 to 6 months. Schizophrenia is more than 6 months. Schizoaffective is more than 1 month. Okay. So for schizoaffective, the criteria is major mood episode or mania, more than 2 weeks of psychotic symptoms without mood symptoms. There is no mood symptoms happening, but there is like psychotic symptoms present. Delusional disorder, more than one delusion for more than 1 month. Substance-induced psychotic disorder, onset during intoxication, basically after drinking alcohol, taking cannabis or something. Secondary to mood disorder, mood symptoms dominant, okay, delusion and hallucination congruent. Don't worry about this table, we're gonna do this in detail like right here. All right, so schizophrenia, very important. Schizophrenia, according to DSM-5 diagnostic criteria, these are the following things that the patient needs to show. Only then, if these things are present, you can say that yes, your patient has schizophrenia. Okay. Okay, So the first thing that you check is two or more following each present for a significant portion of the time during the 1 month period or less. Okay, so at least one of the 1, 2, 3 should be present. What is number one? Delusion. The patient should think something that is there. It could be erotomaniac, it could be persecutory, it could be a delusion of reference, it could be nihilistic, it could be any delusions that we studied. One, hallucination, either auditory, visual, or some sort of hallucination is present, or disorganized speech, frequent derailment or incoherence while speaking. Grossly disorganized catatonic behavior, negative symptoms. Diminished emotional response, avolition, alogia, anhedonia, such symptoms. Okay, so at least one of the 1, 2, or 3. So between the 5, we need at least one from these top 3, either delusion, hallucination, or disorganized speech. For significant portion of the time since onset, the distribution level of functioning major work, so their work or interpersonal relationship has to be affected. Okay, and previously everything was normal and suddenly now there's continuous signs of disturbance persist for at least 6 months. Okay, this 6 months period must include at least one of the major symptoms. Okay, active phase symptoms, odd beliefs, unusual perceptions should be present. Schizoaffective disorder, depressive or bipolar disorder with psychotic features have been ruled out. Okay, if there is a schizoaffective, there is a depressive, or there's a bipolar mood, it's not schizophrenia. You cannot put it there in that category. The disturbance is not attributable to the physiological effects of the substance, such as drug abuse or medication. These changes should not be because of any drug abuse or medication. It has to be from the inside. If there's a history of autism spectrum disorder or communicator disorder of childhood, additional diagnosis of schizophrenia is made only if the prominent delusion or hallucinations in addition to required symptoms. Specifiers, type of episodes: first episode, multiple episodes, continuous, acute phase, partial phase, remission phases. Okay. Epidemiology. This is the prevalence. Male to female ratio is 1. Okay, suicide risk is high, so always assess the patient for suicidal ideation. Etiology is multifactorial, genetic 40%. Okay, in this twin, zygote, and everything, not really important. Neurochemistry, kind of important. Dopamine hypothesis, GABA, glutamate, ACH dysfunctions are thought to be involved. Neuroanatomy, decreased frontal lobe function, asymmetric temporal limbic function, decreased basal ganglia function, neuroendocrine, abnormal growth hormone, prolactin, cortisol, and ACTH. Okay. Neuropsychology, there is obviously global defects seen in attention, language, memory, disruptive connectivity. Okay. Pathophysiology, neurodegenerative theory, you can read this on your own. This is not that important. Comorbidity, important. Substance use disorder. Okay, you have to check for any substance use disorders, any anxiety disorders, any other disorders, and check for such diseases such as metabolic disorders. All right. Now, how do you manage schizophrenia? Very important. There is 2 types. There's biological and there is psychological. Biological, acute treatment maintenance, you have to give antipsychotics. Okay, risperidone, apiprazole, haloperidol, both atypical and typical, both can be used. Okay, clozapine is a steroid. If you have tried the management with risperidone, aripiprazole, haloperidol, paliperidone, then even then the patient is not improving, then you give clozapine. Okay, clozapine has high side effects, that's why we don't give it as first line. Okay, or if basically the patient is not taking the medications, you can give long acting injectables, LIA or depot. Okay, shown to be more effective. Basically it's a depot injection under the skin, or you can give them intramuscular every 2 weeks. Adjunctive treatment, you cannot treat schizophrenia only with antipsychotics. Always remember, schizophrenia, one antipsychotic and one mood stabilizer. Okay, so you have to give them for aggression and impulsiveness. Lithium is a star here. You can give lithium, you can give valproate, you can give carbamazepine. You can also opt for ECT. Maintenance treatment for at least 2 years after the first episode. So if the first episode happens today, so for the next 2 years, they have to continue the medicine. Okay. And if the patient has had multiple episodes, then they have to continue for 5 years. And this was the biological. Psychological is psychotherapy. Okay, individual and family. Remember, here you have to give psychotherapy to the family too, because they will obviously be at the suffering end too with the patient. Supportive CBT. Okay, ACT, assertive community treatment, mobile mental health teams that provide individualized treatment in the community and help patients with medication adherence, basic living skills, and social support. Housing, you offer them housing, social skills, and training and employment. Course and prognosis, basically majority of the individuals display some type of prodromal phase. Course is variable, some can exacerbate, some go into remissions. Okay, positive symptoms typically diminish with treatment. Negative symptoms tend to be more persistent. Remember, the positive symptoms are delusion, hallucinations and stuff. Negative symptoms where they were like, just losing their human touch. They stop talking, they stop socializing, they just become very numb. Over time, 1/3 improve, 1/3 remain the same, and 1/3 worsen. Okay, what are some of the good prognostic factors? If there is acute onset, later age of onset, shorter duration of this episode, female gender, good cognitive functioning, good pre-morbid functioning, no family history, presence of affective symptoms, absence of structural brain abnormalities, good response to drugs. These are all the positive factors that will help us understand if the patient is going to do good or not. So when we discussed the behavior, these are some of the behaviors that is very specific to schizophrenia. This will help you differentiate on your MCQ stem that, okay, this is schizophrenia that we're talking about. Number 1 is catatonic stupor. The patient is fully conscious, but they are mute and unresponsive, immobile, maintaining bizarre position for a very long time. They will just sit, staring at the wall the whole day. They don't move, they don't do anything. Catatonic excitement is exactly opposite of stupor. Here the patient is like rocking back and forth, moving continuously, they're a little agitated. Mannerism is basically they will just keep doing weird face activities like grimacing or saluting or just doing something. Echopraxia is imitates movements and gestures of other. If you try to do like bob your head left or right, they will keep doing that. They'll just keep copying you. Automatic obedience, okay, carries out simple old-fashioned commands but in a robotic manner. If you ask them to lift their left hand, they will lift both the hands in a robotic manner. Negativism is they will refuse to cooperate, and inappropriate affect, neglect and self-care behaviors, random shouting. These behaviors are very specific to schizophrenia. You see this on the stem, just know that it's schizophrenia. Yeah, so we have covered schizophrenia. Now we're going to talk about schizophreniform. Okay, so schizophreniform is if the symptoms have extended past 6 months of the diagnosis, then it becomes schizophrenia. Schizophreniform is anywhere between 1 to 6 months. More than 1 month, but less than 6 months. With or without good prognostic factors, acute onset, confusion, perplexity, could feel morbid. With catatonia, basically the treatment is similar to schizophrenia. The prognosis is better than schizophrenia. Brief psychotic disorder, basically the episode lasts for at least 1 day, but less than 1 month. Okay, brief, very briefly. Specifiers with or without mark stressors, with postpartum onset. Postpartum psychosis is very common with catatonia and stuff. Treatment is secure, safe environment. You give antipsychotics, anxiolytics. Basically, this patient is anxious, you just try to calm them down. Prognosis is again very good and self-return limiting. Next we have is schizoaffective disorder. So basically, schizoaffective is an uninterrupted period of illness during which there is major mood episode congruent with criterion A of schizophrenia, delusion or hallucination for 2 or more weeks in the absence of major mood disorder during the lifetime duration of illness. Next is symptoms that meet the criteria for major mood episodes are present and the majority of total duration of the active phase, residual phase. The disturbance is not attributable to the effects of substance or any other medication, first episode and multiple episodes of severity. Common 1/3 prevalent as schizophrenia, same treatment as schizophrenia, between that of schizophrenia and mood disorder. Okay. Basically, yeah. Yep. So next we have delusion disorders. Okay. I think we will cover the next topic in the next part of the lecture. Thank you.